Welcome to our Video History Library. Our person to be interviewed today is Dr. Douglas Laube, past president of the college. Doug, thank you very much for being here with us.
You're welcome. My pleasure.
Let's begin with a little bit of your background first for our people who review this. Where were you born?
I was born in Calcutta, India, toward the end of World War II. My father was a flight surgeon with the China National Aviation Corporation, which was the hump flying group that took in supplies to West China from India during the latter part of World War II. Then I moved to China when the war was over with my parents and basically lived there until I was 5 years old when we had to move to this country because of the government overthrow in China.
And where did you move when you came to this country?
Moved first to San Francisco. Lived there for a short period of time while my dad looked for jobs. He found a fellowship in Boston, of all places. So 3,000 miles away, we packed into a used 1949 Ford, my mom and dad and 4 kids, and drove cross-country to Boston, spent a year there where he did some postgraduate training in general surgery. And then from there moved back to Dubuque, Iowa, my hometown.
And he has recently passed away?
He passed away a few years ago at the age of 91, and my mom passed away just 2 years ago at the age of 95.
When you moved back to Iowa, were you still in high school?
Moved back to Iowa, actually no, I was in grade school at the time, and spent my entire elementary school schooling in the public schools of Dubuque, Iowa, the junior highs of Dubuque, Iowa, and senior high school.
And where did you go to the university?
Went to college in McAlester College in St. Paul, Minnesota, which was, it is a small liberal arts college in west side of St. Paul.
And then you went to medical school?
Went to medical school, then University of Iowa, starting in 1966.
What influenced you in your life to make you decide you wanted to go to medical school, be a physician?
I think the biggest motivating factor was my dad. I was one of 5 children, and the only one at the time that was interested in healthcare. But Dad used to take me on rounds. In the evening hours, if I wasn't busy, I started scrubbing with him in the operating room when I was a 6th grader at the age of 12. And so I became very interested just because of hanging around with Dad and going and doing his work with him and his interest in my getting involved with the things he was doing.
And then you went on to medical school. Then you decided to take an OB residency.
Right. I did a rotating internship in between because it was right in the twilight years of the rotating internship. Did a residency in OBGYN at the University of Iowa.
Why did you choose OBGYN?
Well, I think at the time I had very good medical school clerkship experiences as a junior med student in gynecology, and a lot of that was surgical gynecology. And I think my father's influence as a general surgeon led me to realize that there was surgery involved with gynecology. And in my senior year of med school, I did obstetrics and realized I could do obstetrics, which I thought was a lot of fun, at least most of the time, and also have a surgical side of the specialty. So I think the combination, and we still hear this a lot with students today, that they like the combination of medicine, obstetrics, and surgery. So I think that applied to me almost 40 years ago.
Who was your chair at the University of Iowa at that time?
My chair was Dr. William Keatle, and he was my chair as a resident, and then he was chair when I finished my military obligation and came back from my Navy tour. And he was the one that encouraged me to do a master's in health science education rather than the fellowship in oncology that I thought I was going to do. So my fellowship, in effect, was in education rather than in cancer.
And where did you take that?
I did that at the University of Iowa School of Education. So I did my coursework over the course of 2.5 years and worked in the department part-time, working clinics and taking call.
Well, you're known as one of the premier medical educators in our specialty, so I assume that was probably a very good suggestion you made.
Well, it has served me well so far, and I've enjoyed every minute of it.
After you finished that training, did you stay in Iowa?
Yes, I stayed there on the faculty for another 17 years, starting in 1978, as a full-time assistant professor after finishing my master's degree. And then became clerkship director a year later and ran the third-year medical student clerkship for the following 16 years before moving to Madison in 1993.
Now, your role in Madison was?
I was recruited to Madison, the University of Wisconsin, to be the chair of the department.
Why would you take a chair after leaving Iowa? What was your thinking?
Well, I think after 17 years at Iowa and realizing that I had by then begun to be quite involved with a number of ACOG activities, particularly through CREOG, and at that time APCO, which was a somewhat different organization from what it is now. And I was really influenced a lot by one of my mentors, aside from Dr. Keetle, Dr. Robert Kretschmar, who in the late 60s, I believe, was actually the chair of District 6 of ACOG. He got me involved with the college and encouraged me to pursue education, so that when the time came to be a chair, I jumped at the chance because I felt I could have a bigger influence as a department chair who is interested in education rather than some other area of medical or OB-GYN research. What
was your first role at the college?
My first role at the college was actually it was as a presenter when I was still a junior fellow when the District 6 meeting was in Milwaukee. I think this was 1978 or 79. I had just finished my master's in education, and I had written a paper on the use of simulation in OBGYN. And it was a paper that was accepted, Kretschmar and I wrote the paper, was accepted by the Journal of Medical Education as a novel way to teach acute GYN entities using live patients. So we wrote the paper on the programs that I had written for these patients to simulate as one of the very first patient simulation papers that had occurred in the literature.
That was rather forward thinking compared to what we're doing in simulation today.
Yeah, and it was very expensive too, because we scripted these 4 patients, different entities: ectopic pregnancy, appendicitis, torsion of a corpus luteum. I forget the other entity, but they were all acute patients, and they actually simulated findings, pain-related findings on pelvic exam. And then the students would have to write orders based on what the diagnosis was, admit the patient, and write down a disposition. But it was a new, novel concept. It was based on the concept that Dr. Kretschmar had developed using the Gynecology teaching associate. We figured we'd take it a step further and program these patients with acute entities.
How did you recruit these patients?
We recruited them from an organization in Iowa City at the time called the Women's Resource and Action Center, WRAC. And these were a group of 60s and early 70s women, vocal feminist advocates that were in Iowa City and in many university communities around the country at the time, were pushing for more better reproductive outcomes for women. And they were part of a national network that was interested in educating medical students better towards improving women's health care. So from that pool of women, Dr. Kretschmar was able to keep our gynecology teaching associate program going for many years using departmental funding to pay the teaching associates to show up every Tuesday and Thursday and provide material for education for the med students.
I seem to recall that some of the first papers that he did were related to teaching just the basic pelvic exam.
Yes, that's what it was. We taught basic pelvic anatomy. The patients themselves actually helped serve as the best educators because they all learned the anatomy very well. And they, in fact, would teach in pairs. There was the patient herself, and then there was the patient advocate, and the two of them together would teach groups of 4 med students learning how to do basic normal pelvic examination.
I think that's been accepted as probably one of the premier teaching pelvic exams in the world today.
I think it is. Most medical schools now use that.
Yes, I remember Bob Well teaching me how to teach our people to do that. Well, tell me what other positions you've held in ACOG besides that.
Well, from that time I gave that paper, I got very much more excited about being part of ACOG. It was my first regional presentation. And then from there, and with Kretsch's support and influence, I was able to participate in junior fellow activities, passed my boards a couple of years later, and became a fellow of the college and decided that I would become interested in the educational activities of the college. And at the time, your predecessor was the executive vice president, and Dr. Harry Fisher was the director of education. And I think Dr. Keetle must have leaked the word out that I was interested in education. And one thing led to another, and I was appointed to the in-service exam item writing committee in I think it was 81, having given a couple of other presentations at District 6 meetings. Started on the in-service exam committee, and in the following year, I was appointed as an oral board examiner for the American Board of OBGYN. So I started out fairly quickly after my own certification, and from there served on a variety of educational and education development committees for the college. Eventually then on various committees, education committees, primarily the Technical Bulletin Committee. At the time it was called Technical Bulletin. Became chair of the GYN Technical Bulletin Committee, and a variety of other activities since then. I can't remember all of them, but there have been a lot.
There have been a lot.
Yes.
But you've also been involved with the national boards.
Yes.
Could you tell us a little bit about that involvement?
Yeah, the national boards, for those that might not know this, is the entity that is responsible for single pathway to licensure in this country, using what is referred to as the USMLE, the United States Medical Licensing Exam. I started working with them along the same lines with item writing development for the licensure exams for medical student graduates, primarily because of my contact with the in-service exam through CREOG. In other words, CREOG, when I was on the item writing committee, used the national board as its psychometric consultants. So every year, one of our 3 meetings every year occurred in Philadelphia at the national board offices. Well, at that time, OBGYN was what they referred to as a contract entity. We contracted to them for psychometric services. And through those contacts, they saw me as a potential item writer for their own committees. So they got me involved in writing for their committees. So now I was writing for residents on one hand and medical student graduates on the other, and began my activities with them, which now date back to 22 or 3 years.
And you're still involved with them?
I'm still involved with them on their national board, the board of the national board now as a item writing, as a test committee member representative.
And they pretty much are the standard, as I understand now.
Yeah, yes they are. I think they are the largest, most well-recognized testing agency as we refer to it, the House of Medicine, all specialties. And they are very well respected around the world. And as I think you probably know, they're developing worldwide programs now as well.
Speaking of worldwide, I understand that you also had involvement in Afghanistan.
Yes, I have. Mm-hmm.
Would you care to tell me?
Yes, I was interested in Central Asia dating back to the mid-90s because of my involvement with a group that was funded by a non-government organization which sent me to Kyrgyzstan and Kazakhstan a number of times to do field clinics in women's health, develop outpatient facilities, which were housed actually in the back of an 18-wheel trailer truck. And there was a little pediatric clinic, a GYN clinic, and a dental clinic. And I was recruited as the person to help set up the GYN clinic. From there, 3 or 4 years later, under the first Bush administration, our former governor from Wisconsin, Thompson, was appointed as Secretary of Health and Human Services. And he was particularly interested, certainly in the couple of years following 9/11, was interested in some social rehabilitation projects in Afghanistan. He didn't know where to start, and he had a particular interest in one maternity hospital in the middle of Kabul. This is a maternity hospital that is doing approximately 16,000 deliveries a year, where the maternal mortality was approaching 1,000 per 100,000 births. He then was interested in developing an education project for the resident physicians who worked there. He called the chancellor of the University of Wisconsin, because that was his former state, whom he knew personally. The chancellor called the dean, because the chancellor didn't have any clue about what to do. The dean knew of my interest in Central Asia, and he called me, and he asked me to put on the faculty meeting agenda for our following meeting the next Monday the issue of asking for volunteers to go to Afghanistan. Well, this was 2003, and there were no volunteers coming out of our department. So I said, I'll go. I'll just go to do this. It was time for me to start looking at other things to do anyway, and so I volunteered to go under this HHS program for Thompson. And so I made a number 3, actually, consulting visits to help set up infrastructure for residency education in this, what was in effect a chaotic maternity hospital. And unfortunately, my activities were cut somewhat short, because with the second Bush term, Thompson was no longer HHS secretary, and his successor no longer had the interest in this project that we had started. So the project, after 3 visits, and actually having made some progress with the curriculum development there, died for lack of funding. But we're looking again to see about new methods to get back over there and re-engineer our project under Department of Defense funds.
Is there anyone doing any work there now?
There is an NGO working there now, which hires volunteers. In fact, we were working with this NGO, the International Medical Group, IMG, working with them in our project, and in fact, they are still continuing their work, seeking volunteers from mostly Western Europe and to some extent from the USA. But we are no longer involved with it from the standpoint of the Department of Health and Human Services.
What is your role at Wisconsin today?
Well, today I am a professor in the department, primarily working with medical students. I have sophomores and freshmen. I counsel third-year students regarding their career, if they're interested or potentially interested in OBGYN. I worked with residents in the clinics, resident clinics, and starting as of about a month ago, I'm going to be starting to help set up a new family planning fellowship that my current chairman wants me to work on to get recruiting a second faculty member in family planning and ultimately set up a formalized fellowship in that.
You mentioned medical students.
Mm-hmm.
You are the editor, or at least have been the one to put together one of the premier OBGYN texts for medical students. And currently you're working on that within the college. Could you tell us about that textbook? Yeah,
it's a pretty timely subject, because this meeting here in Chicago is the rollout of our book. This is a textbook that this is now the 6th edition. I co-authored the original first editions with 5 of my colleagues who are all interested in medical education from different parts of the country. And it occurred to two of us, Frank Ling and I discussed this about a year and a half ago, that wouldn't it be nice if we could involve another entity, in particular the college, in this textbook? Because the five of us original authors had begun to use younger authors to provide contemporary comment in the chapters we had originally written. So we wanted to keep it current. So it occurred to Frank and me one time at a meeting that I think it was over a dinner, that we should approach the college and try to engage the college in helping us develop this next edition. This is now almost 2 years ago. The college was receptive to it, and what we did was engage the Junior Fellow College Advisory Council, the JFCAC, in the update project of the textbook, so that we obtained, I think, of the JFCAC members, we got the vast majority of them to volunteer to contribute to the editing and the updates of all the chapters of our book. And so they contributed, we edited what they edited, we helped them rewrite things. Some contributed a lot, some not quite so much. The original authors then served as the senior reviewers for all of these updates. And one thing has led to another, and the book is rolled out literally today, this morning in the ACOG booth, and we anticipate that, that this will have tremendous appeal to our med students around the country, as well as resident physicians in other specialties. It's a basic GYN textbook, but it uses much of the college educational material as its background information. So going into this project, we were already the best-selling student textbook in the nation, and we anticipate coming through this project into the next couple of years, we will even see a bigger distribution of the textbook. So we're very happy to have been involved with the college.
Doug, you've been active in the college at a wide variety of levels, starting from junior fellowship clear through to the presidency of the college. What is your most memorable experience that you've had within the college?
I think, oh boy, there are lots of memorable experiences. Some of them I probably can't even relate on tape. I'm just kidding. But I've had so many wonderful professional experiences that I think it capped off with the inauguration in Washington, D.C. Now 3 years ago, and the activities that followed that inauguration, having become president, and my connections with people around the world. I have an interest, and maybe this goes back to my childhood, an abiding interest in world health, women's world health. And I think the college presidency enabled me to take another step towards making connections with my colleagues around the world to really see what it is that women's health is and perhaps what it isn't in much of the world, and to see how important it is as a global issue. So I'm very, I guess the global connections is my short answer.
As a corollary to that, what is your most disappointing experience?
I think the most disappointing experience I have had as it relates to college activities is to see how little attention our collective legislative leaders paid to our need for litigation reform. I think having represented the college on the front side of that in terms of our efforts to try to make reform in healthcare litigation, that to see how many deaf ears it fell upon was very disappointing and somewhat disillusioning for me.
If you could make one change in ACOG, what would that be?
I think if I could make one change, I would expect, ask, help, develop, whatever word you want to use, a meaningful interdisciplinary coalition of women's healthcare providers that could go forward with a unified voice in approaching the practice of women's healthcare in its expanded form to and for the American public. taking that another step, I would like to then see that same sort of coalition of women's healthcare providers speak with a unified voice in helping the global women's healthcare issues that I just referred to.
Doug, what do you see as the future of our specialty? You're very much into the education and into what is happening.
Well, I see, as I circulate with the junior fellows and now with students and residents in particular, that I'm really beginning to believe and accept, in fact I have for some time, the notion that our future practitioners want something different from what I learned. Not necessarily different in a bad way, but just different in that the quantity of what they have to learn, what they have to practice, what they have to consider in their practices is considerably different from the volume of material that I had to learn, which was a lot less. So I see the future of education as needing to be, as I refer to it, more learner-driven. I see the need for individuals to be able to help decide the course of their own education so that they can do best what they like best. That's something I've been telling students and residents for my whole career, is that you'll always do best what you like best. And helping to revise our educational system in a way that addresses the needs of the future practitioner through the needs of the future learner. And in that regard, I'd like to participate and be part of helping to restructure both our undergraduate and graduate education in women's health, in particular OBGYN, to meet those needs.
Given your background and the activity you've had, a young medical student comes to you and says that they're thinking about going into OBGYN. What advice would you have them today, give to them today?
Well, I just did give this advice last Friday with my sophomore students. I had a group of 12 of them. We were doing case discussions, and I just said to them, they were ending their second year, going into their third. I said, OBGYN is the best specialty you can think of because half the world's patients are accessible to you. B, you have a chance to make an impact in preventive medicine, public health, because women's health is public health in most of the world, an important issue. And I told them, I said, you can pick and choose just about anything you want to do within the concept of obstetrics and gynecology as it relates to women's health. So flexibility, the excitement of a variety of different practice modes, and the application on a mass basis for public health, I think are the things that I encourage them to think about.
In your own university, do you have a lot of students that you meet with that have decided to take an obstetrical specialty training? Actually,
we are at about the national average of around 7%, 6.5% to 7%. We have 154 or so medical students, so we aren't particularly high, but we're not low. We're at the average, and we have a very active student interest group of about 60 to 70. So my goal is to take those 60 to 70 who are interested and thus benefit from the college publications and all the membership activities that we provided them, and to increase the group that actually want to match into residency. And we're slowly making headway in that, I think.
Doug, it's been a pleasure to talk to you today. You are certainly one of the leaders in education, our specialty, and I think your influence has had major changes in the college approach to it. Thank you very much for being here with us, and if you have any parting remarks you'd like to say, we'd be happy to hear them.
Nothing other than to appreciate the invitation to be able to talk with you and to relay some of my thoughts, and if you need another half hour or an hour or 10 hours, I'd be happy to provide it sometime.
I know you would. Thank you very much.
Thank you.
Okay.